Marilyn brought a grocery bag full of pill bottles to her checkup. 11 of them, everyone prescribed by a doctor who meant well. Not one bottle said, "may affect your memory." Together, they were doing exactly that. She wasn't losing her mind. She was quietly losing it to something sitting in her own bathroom cabinet, a few milligrams at a time. Tonight, I'm counting down the 9 medications behind this pattern, and around the halfway mark, I'll show you the 5-minute math that would have caught hers a year sooner. I'm Dr. William, 15 years in emergency medicine, and Marilyn, 74, a retired school secretary from just outside Dayton, is not rare. Someone who once ran circles around the family starts losing the thread, and everyone around them, their own doctor included, files it under ordinary aging. Sometimes that's correct. Sometimes it's chemistry. Sitting in a bottle with a childproof cap nobody reads past the dosing instructions. Right now, 7.4 million Americans 65 and older are living with Alzheimer's, and that number is projected to climb past 13 million within decades. Nobody knows exactly how many of those cases started in a medicine cabinet instead of the brain itself. Here's what surprised me most once I started looking closely. It's almost never one drug doing the damage alone. What usually happens is 2 or 3 ordinary prescriptions pulling on the same rope from different angles, while nobody ever sits down to total up what they're doing together. That's the real story under nearly every case tonight. So here's the plan. 9 medications, ranked from the one that slides under the radar most easily to the one I'd call the most damaging on its own. Keep a rough mental tally, because right past the halfway point, I'll hand you the exact 5-minute method for adding up your own number. Free. The same scoring approach pharmacists use during a real medication review. By the end, you'll know which bottles in your cabinet are worth a phone call this week and which genuinely aren't worth losing sleep over. Number 9 is diphenhydramine. Its drugstore name is Benadryl. The go-to pink pill for a rough night's sleep or a stubborn cold, no prescription required, so most people assume that makes it harmless. What it's doing inside your skull tells a different story. Diphenhydramine is an anticholinergic. It blocks a brain messenger called acetylcholine, the signal that turns "this is happening now" into "I'll remember this tomorrow." Picture acetylcholine as a key, and your brain cells as millions of locks that need opening constantly just to file one ordinary day into memory. This drug jams a portion of those locks shut, night after night, and the older you get, the fewer keys your brain is making in the first place, so the jam lands harder. A large study tracking cumulative anticholinergic exposure in adults 65 and older, published in JAMA Internal Medicine, found dementia risk climbing with how much of these drugs someone took and for how long. This isn't a rare freak reaction. It's a dose and duration relationship, and most nightly users have no idea a clock is running at all. What to do? Read labels. Anything marketed PM, nighttime, or allergy relief is very often diphenhydramine under a different name. For allergies, loratadine, Claritin, or cetirizine, Zyrtec, don't cross into the brain the same way and hold up far better long-term. Don't stop anything on your own. Bring the bottle to your doctor or pharmacist. But retire the idea that no prescription required means safe for my memory. 2 different questions. Number 8 is the proton pump inhibitors, omeprazole, Prilosec, and esomeprazole, Nexium. They switch off stomach acid for heartburn and reflux, and people often stay on them for years because quitting invites the burning right back. Here's what almost never comes up at the pharmacy counter. Stomach acid is what your body needs to strip vitamin B12 loose from food, and B12 insulates the wiring running through your nerves and brain. Turn that acid down long enough, and B12 quietly drops out from under you. Magnesium and calcium go with it. 2 minerals your brain cells need simply to fire without static. Starve neurons of that trio and you get misfires and memory slips that can mimic early Alzheimer's almost perfectly. A 2016 study in JAMA Neurology followed more than 73,000 adults 75 and older. Regular PPI users carried a 44% higher risk of a later dementia diagnosis. Now, I want to be straight with you. Newer analyses have pushed back on how much of that number belongs to the drug itself versus the reason someone stays on a PPI for years in the first place. That debate isn't settled. But the nutrient story doesn't need the dementia number to hold up in order to matter. B12, magnesium, and calcium deficiency causes real, reversible brain fog, no matter how that larger question shakes out. What to do? Daily PPI use is worth a real conversation about why you're on it and for how long. Many people can step down to a gentler class called H2 blockers. Famotidine, Pepsid, carries a much smaller cognitive footprint. And if a PPI is staying in the picture, ask whether an annual B12 check makes sense. Number 7 is Oxybutynin, sold as Ditropan, prescribed for that sudden urgent need to reach a bathroom. The relief is real, and so is the dignity it restores. But Oxybutynin blocks acetylcholine, the same memory signal diphenhydramine jams, and it crosses into your brain unusually easily. Research following adults over 65 on strong anticholinergics like Oxybutynin for more than a year found a roughly 50% higher risk of a later dementia diagnosis, nearly a coin flip, and almost none of those patients were ever warned. They heard, "This will calm your bladder," and nothing about the mind. Your bladder and your brain don't have to compete. Mirabegron, Mirbatric, works through a completely separate pathway and never touches acetylcholine. A trial built specifically to test cognitive safety in adults 65 and older found no measurable dip in cognitive scores after 12 weeks. Raise it at your next appointment. This may be the easiest swap on the whole list. Number 6 is statins. Simvastatin, Zocor, and Atorvastatin, Lipitor, among the most prescribed drugs on the planet. They do serious, valuable work lowering cholesterol and cutting heart attack and stroke risk. Nothing here is an argument against taking one. Your brain runs almost 60% fat, and cholesterol builds the myelin sheath insulating each nerve fiber, which is the theoretical worry behind a 2012 FDA label caution about short-term fog. Here's the honest complication. A large study in the Journal of the American College of Cardiology tracked nearly 18,500 adults 65 and older for 5 years and found no increased dementia risk among statin users at all. Compared with almost everything else on this list, the case against statins and lasting memory loss is genuinely thin. If you're on one, this is not the one to lose sleep over. Don't quietly walk away from a medication protecting your heart over a link. The evidence doesn't back up strongly. Quick recap. Diphenhydramine and Oxybutynin jam your memory signal directly. PP is starve your nerves of raw material, and statins, despite their reputation, turn out to be the weak link in this story, not the strong one. 3 medications to go before the number I owe you. Number 5 is the Benzodiazepines, lorazepam, Ativan, diazepam, Valium, alprazolam, Xanax, near the top of the list for anxiety and sleep. They boost GABA, the brain's built-in dimmer switch, and in the moment, they genuinely feel like rescue. Several large studies have tied longer-term use in older adults to a higher rate of later dementia diagnosis. Here's the honest complication. This research area carries a live scientific disagreement because anxiety and insomnia can themselves be early signals of a brain already changing, sometimes years before diagnosis. I won't pretend that's settled. What I can say without hedge, while you're on one of these, it produces real, measurable sedation, learning slows, reaction time lags, and quitting cold after regular use can bring anxiety and insomnia roaring back worse than before, sometimes dangerously. Weeks of regular use is the line. Past that, never taper alone. Buspirone works without the sedation, and there's a specific tested brochure for this exact drug that I'm saving for a few minutes from now. Number 4 is Amitriptyline, Elavil, an older antidepressant still handed out for nerve pain, sleep, even migraines. That flexibility is exactly why it spread so far. Underneath, it's one of the strongest anticholinergics still in everyday use. Researchers tracked cumulative anticholinergic exposure in over 3,400 adults, 65 and older across roughly a decade, publishing in JAMA Internal Medicine. The heaviest exposure group carried a 54% greater dementia risk than the lightest exposure group. It doesn't even take a large dose. A small nightly amount, sustained for years, can erode cognition with no dramatic red flag. Duloxetine or gabapentin can cover nerve pain with a much lighter footprint. For sleep, melatonin or low-dose doxepin. For mood, sertraline or escitalopram. Number 3 is paroxetine, Paxil, one of the most prescribed SSRIs, and generally viewed as gentler than an older drug like Amitriptyline. Here's the detail almost nobody mentions. Paroxetine is the one SSRI with genuinely strong anticholinergic activity, leaning on the identical door that oxybutynin, diphenhydramine, and amitriptyline all push against. A review comparing older adults across SSR is found paroxetine users showing measurable drops in memory, word finding, and attention at higher rates than people on other antidepressants in that family. There's a tool that ties this whole list together. The Beers Criteria, published by the American Geriatric Society, the clinician watch list for medications that deserve extra scrutiny in older adults. Paroxetine's on it. So is diphenhydramine, oxybutynin, amitriptyline. One phrase worth memorizing for your pharmacist. Is this on the Beers list? If paroxetine is yours, ask about sertraline or escitalopram instead. Let's pause the countdown, because this is the section I built this whole video around. Most people assume all 9 of tonight's medications attack your brain the exact same way. They don't, and that mix-up is exactly why nobody ever tallies the real danger. What you've heard so far are 3 separate doors into your brain. Door 1 is blockade. Diphenhydramine, oxybutynin, amitriptyline, and paroxetine all jam the same acetylcholine lock memory formation depends on. Door 2 is starvation. PP is quietly choke off B12 and minerals your neurons need to function. Door 3 is sedation. Benzodiazepines turn down the volume on your entire system while you're taking them. 3 distinct mechanisms, 3 separate reasons an ordinary safe prescription can leave you foggier than anyone warned you it might. Door 1 you can actually turn into a number tonight, in about 5 minutes, using the same scoring approach hospital pharmacists use during a real medication review. It's called the Anticholinergic Cognitive Burden Scale, ACB for short. Every medication scores 0 to 3. 0 is no real effect. 1 or 2 is mild to moderate. 3 is strong, unmistakable anticholinergic activity. Diphenhydramine, oxybutynin, amitriptyline, and paroxetine all land on a 3. Total every 3 across your cabinet, and a cumulative score of 3 or higher is roughly where research groups start seeing dementia risk climb in a way that matters. Here's the 5-minute version. Gather every bottle, prescription, over-the-counter, supplements, the whole shelf. Search each one against a free anticholinergic burden calculator online. Each lookup takes about 30 seconds. Land at 3 or higher, and that printout belongs in your bag for your next appointment. With one sentence attached, can we look at reducing my total anticholinergic burden? Let's run Marilyn's numbers. Say 3 of her 11 bottles turn out to be a nightly diphenhydramine, an oxybutynin, and an Amitriptyline left over from a nerve pain flare nobody had revisited in 2 years. 3 medications, each a 3-dye, a cumulative score of 9, sitting quietly under the other 8 bottles, and not one person had ever added them together in the same sitting. 9 is the kind of score that earns a same-week callback from a geriatric pharmacist. That math took about 90 seconds with her chart in front of me. It'll take you about the same tonight, at your own kitchen table. Keep that number in your head. 2 more to cover, and they're the 2 that worry me most. Number 2 is the antipsychotics, quetiapine, Seroquel, risperidone, Risperdal, olanzapine, Zyprexa. Built for serious psychiatric illness, schizophrenia, bipolar disorder. That's not what most seniors are actually taking them for. Today, they're handed out off-label for sleep trouble, restlessness, the agitation that can come with dementia itself. I want to be direct about how serious this is. In 2005, the FDA required its strongest possible warning, a black box warning, printed on every bottle. These drugs increase the risk of death in older adults with dementia-related behavioral symptoms, not may cause side effects. Death, mostly from cardiovascular events and infections. Separate research found a meaningfully higher rate of cognitive decline within a year in residents started on these purely for behavioral symptoms. Here's the hopeful part. This is one of the few places on this list with national-scale proof that fixing it works. Starting in 2012, a federal initiative pushed nursing homes to review and cut unnecessary antipsychotic use. By early 2017, antipsychotic use in long-stay residents had dropped 34% nationwide. If you have a parent or spouse in a facility, you're allowed to ask directly at the next care conference, is he on an antipsychotic, and has anyone reviewed whether it's still needed? Number 1 isn't a 10th medication. It's the compounding math sitting underneath everything I've told you tonight. A federal health survey found 22% of American adults 40 to 79 are taking 5 or more prescription medications regularly. Narrow that to 60 to 79, and it climbs to roughly 35%. More than 1 in 3 of you watching this. Picture an ordinary version. A senior on diphenhydramine nightly, Oxybutynin daily, Amitriptyline for nerve pain. Each alone might produce a small effect. Stack them, and that's a door 1 score of 9-dye, and the burden compounds fast, not gently. There's a second reason this stacking matters, and it isn't a diagnosis 10 years out. It's more immediate. A well-designed 10-year study that tracked bone density directly found the independent link to fracture disappeared once researchers accounted for the health conditions behind the prescription. What didn't disappear is simpler. Drowsiness, dizziness, blurred vision. Stack 3 of these drugs, and that's what puts someone on the floor at 2 in the morning. A hip fracture at 78 isn't just an injury. For a lot of people, it's the event that ends independent living for good. Here's the hopeful part, and it's the entire reason I made this video. Medication-induced cognitive decline is often reversible when caught early. Lower the burden, and many people regain real clarity and memory within weeks to months. Not a guarantee, but often enough that it's always worth checking before accepting it's just aging as the final answer. So let's talk about how that removal happens safely, because just stop taking it is exactly the wrong instruction. There's a 2-page patient brochure tested in a real randomized trial in JAMA Internal Medicine to help older adults have this exact conversation about benzodiazepines. 27% of people who simply received and read it had completely stopped their benzodiazepine within 6 months. Compare that to under 5% with usual care. It's free, searchable online as the Empower brochure, and printing it out before your next appointment may be the single highest leverage thing you do after watching this video. Please don't stop any of tonight's medications abruptly, especially benzodiazepines or antidepressants. That deserves a real conversation. not a decision made alone tonight. And if you haven't noticed any memory problems at all, this still applies to you especially. The whole reason this pattern hides so well is that it builds before it announces itself. One thing on timing, because not everything here is equally urgent. If memory changes have built gradually over months, write down what you're noticing and bring it up at your next routine visit. If it's new or has clearly worsened over recent weeks, call your doctor's office and ask to be seen this week. If someone suddenly becomes confused or unlike themselves within hours, especially with a fall, fever, slurred speech, or one-sided weakness, that's not a medication review conversation. That's urgent care or the ER the same day, and if there's any sign of a possible stroke, call 911 and don't drive them yourself. If 30 seconds is all your memory keeps from tonight, keep this. Your body tends to whisper before it screams, and where medication is involved, that whisper usually gets misheard as just getting older until somebody sits down and does the addition. 3 doors, 9 familiar medications, 4 of them pushing on the same acetylcholine lock. The PP is rationing your B12, the benzodiazepines turning the volume down, and the stacking math that makes any 2 or 3 together worse than any one alone. Statins earn the lightest worry of the 9. The rest genuinely add up. Perfection was never the assignment. The next useful step is, here's that step. Before the weekend's out, gather every bottle in the house and run each one through a free Anticholinergic Burden calculator online. 3 or higher, and that printout rides along to your next appointment. If benzodiazepines are in the picture, track down the Empower brochure. And if you're on Medicare, your annual wellness visit costs nothing, and a full medication review is exactly what it's built for. Your turn. Which of tonight's 9 are sitting in your own cabinet right now? Say so in the comments, and commit out loud to booking that medication review this week. One last thing. Your fingernails are quietly keeping their own set of records. Early warning signs tied to your kidneys, your blood, even your nervous system. That's where we're headed next. I'm Dr. William. Take care of that brain. I'll see you in the next one.